يلا عشت ايدك. السلام عليكم شباب.
عليكم السلام دكتور.
اليوم محاضرتنا about intestinal obstruction. اوكي، محاضرتين مهمات جدا وحتى بمجال عملكم جدا about intestinal obstruction. We classify the intestinal obstruction to two types, either dynamic or adynamic. Dynamic intestinal obstruction when there is the peristalsis is working against the mechanical obstruction. It may occur in acute or chronic form. While the adynamic اللي هو non-mechanical in which the peristalsis may absent. For example, paralytic ileus من اسمها paralytic ileus ball, paralytic يعني paralysis. Or it may be present but it is non-propulsive form. For example, in mesenteric vascular occlusion or pseudo-obstruction. In both types, a mechanical element is absent. There is no mechanical obstruction. It is defect in the motility. The causes of intestinal obstruction, the mechanical intestinal obstruction divided into three types, either intraluminal or intermural or extramural. Intraluminal, the defect is then in the lumen, like in fecal impaction, foreign body, pezor, or gallstone. It is very rare gallstone causing obstruction to the bowel. Intramural, the defect in the wall, like in stricture or malignancy. Extramural, when the defect is outside the bowel, for example, band, adhesion, hernia, there is obstructed hernia, volvulus, okay, or interception. While adynamic or non-mechanical cause, there is a three type, either paralytic ileus, mesenteric vascular occlusion, or pseudo-obstruction. ناخذها واحدة بالتفصيل بالمحاضرة. What are about the pathophysiology of the intestinal obstruction? In dynamic, راح ناخذ dynamic intestinal obstruction. The proximal bowel will be dilate and develop in altered motility. Below the obstruction, the bowel except normal peristalsis ما عندها أي defect below the obstruction. Show normal peristalsis and absorption until it become empty. At which point it contract and become immobile. ماشي يجيها على مود يصير بها mobility. اوكي، بالبدايه هي normal motility لحد ما يصير بها emptying وبعدين تنتهي الى يصير immobile. هاي distal to the obstruction. While in proximal to the obstruction, the proximal peristalsis is increased to overcome the obstruction in direct proportion to the distance of the obstruction. If the obstruction is not relieved, the bowel become dilated, causing reduction in the peristaltic strength, ultimately بالنهاية lead to the flaccidity, تتعب البول, and the end result lead to the paralysis. Okay, this is a protective mechanism to prevent vascular damage to the bowel secondary to the increased intraluminal pressure by continuous peristalsis. واضح شباب؟ In the proximal segment of the obstruction, there is dilatation of the bowel by two, either by gas or fluid. The gas, منين يجينا الغاز? There is significant overgrowth of the both aerobic and anaerobic organism, resulting in considerable gas production. Following reabsorption of the oxygen and carbon dioxide, the majority of this gas is made of nitrogen and hydrogen sulfide. 90% nitrogen and hydrogen sulfide will make this is very bad or offensive or bad odor gas. The second cause of distension is fluid. This is made up of various digestive juice. Following obstruction, the fluid accumulate within the bowel wall and any excess is secreted into the lumen, while the absorption from the gut is retarded. So dehydration in the intestinal obstruction resulted from either due to reduced oral intake, defect in the intestinal absorption, and loss as a result of vomiting, and sequestration in the bowel lumen called third space loss. What about strangulation? When the obstruction associated with the interference of the blood supply to the bowel or compromise the blood supply to the bowel, called strangulation. When the strangulation occurs, the viability of the bowel is threatened due to compromised blood supply. The venous return is compromised before the arterial supply. على اعتبار البريشر in the venous is أقل considerably from the arterial. So the venous will be obstructed easier than arterial. The resulting increase in capillary pressure lead to the local neural distension, and with the loss of intravascular fluid and red blood cell intramurally and extraluminally. Once the arterial supply is impaired, hemorrhagic infarction occurs to the bowel. As the viability of the bowel is compromised, there is marked translocation and systemic exposure to anaerobe organism with their associated toxin. So it is very easy to note that the patient with the strangulated intestinal obstruction is toxic and feverish due to marked translocation of the organism, especially anaerobic organism. The morbidity of intraperitoneal strangulation is far greater than external hernia, which has smaller absorptive surface to the bacteria and its toxin. So when there is intraperitoneal strangulated bowel, is usually associated with more toxemia and sepsis other than external hernia. The morbidity and mortality associated with the strangulation is depend on age and extent of the strangulation. In the strangulated external hernia, the segment involved is short and the resulting blood and fluid loss is small. When the bowel involvement is extensive, the loss of the blood and circulating volume will cause peripheral vascular failure. What about closed loop obstruction? What do you mean by closed loop obstruction? This occurs when the bowel is obstructed at the both proximal and distal point. It is present in many cases of intestinal obstruction. Unlike cases of non-strangulated obstruction, there is no early distension of the proximal intestine. When the gangrene of the strangulated segment is imminent, a retrograde thrombosis of the mesenteric vein results in distension on both sides of the strangulated segment. Classical form of the closed loop obstruction seen when there is a presence of the tumor in the right side colon with the presence of the competent ileocecal valve. So competent ileocecal valve considered to the obstructing and malignant structure in the right side between them called closed loop obstruction. The inability of the distant colon to decompress itself into small bowel results in an increase in the luminal pressure, which is greatest at the cecum, with subsequent impairment of the blood supply may lead to the necrosis and perforation of the cecum. We discussed the special type of mechanical intestinal obstruction and its cause, then investigation and treatment of each cause of intestinal obstruction. The first one, when the obstruction by adhesion. In the Western countries where abdominal operations are common and adhesions and band are the most common cause of intestinal obstruction, even in our locality. So the most common intestinal obstruction, especially small bowel obstruction, is due to adhesion. In the early post-operative period, the onset of such a mechanical obstruction may be difficult to differentiate it from the transient period of paralytic ileus, which is occur in post-operative period. The common cause of intra-abdominal adhesion when there is ischemic area, for example, site of anastomosis or reperitonization of the raw area, and trauma, vascular occlusion, this area of adhesion, this area of common area that occur in it is adhesion. Foreign material like talc, starch, gauze material, or piece of the gauze, or piece of the sutures like silk. Infection, peritonitis, TB, it is nidus for adhesion. Inflammatory condition like Crohn's disease, radiation enteritis. اوكي شباب وياي؟ اريد صوت، ماكو صوت.
دكتور وياك.
اشتيدك. Any source of peritoneal irritation result in a local fibrin production which produce adhesion between opposite surfaces of the bowel. Only fibrinous adhesion may disappear. It is reversible when the cause is removed, or they may become vascularized, mature, fibrous adhesion, which is irreversible. Okay, Shabab? There are various or several factors that limit adhesion formation. يعني how you prevent adhesions. مثل ما قلنا إذا اكو raw area، إذا اكو area of ischemia، لأن كلهن يعني closure of the raw area ممكن تقلل من chance of adhesion. Good surgical technique بحد ذاتها is a preventive measure for adhesion. Washing of the peritoneal cavity with the saline, normal saline, it is very important to remove any foreign body, any cloth, any piece of the gauze, any piece of the sutures. So the wash of the peritoneal cavity at the end of operation with the saline is very important to prevent adhesion. Minimizing contact with the gauze. Not traumatized bowel by harm or it is a rough attachment of the bowel with the gauze. Covering anastomotic and raw peritoneal surface is a preventive measure of adhesion. This is very important to prevent adhesions to the bowel by these four things. Numerous substances may be tried to decrease adhesion when it is instilled to the peritoneal cavity, like hyaluronidase or hydrocortisone. hyaluronidase موجود اكو أنبولة خاصة ممكن نخليها bottle normal saline and instill to the peritoneal cavity to decrease chance of adhesion. It is very important and a new option to reduce the adhesion. Also hydrocortisone, silicone, dextran, polyvinyl propylene, anticoagulant, antihistamine, non-steroidal anti-inflammatory drugs. These all drugs can reduce the chance of adhesion in the abdomen after surgery. Post-operative adhesion give rise to intestinal obstruction. Usually involve the lower small bowel. عادة involve lower small bowel terminal ileum. Operations for emergency, commonly appendicitis, and gynecological procedure are the most common procedure that associated with the adhesion and usually indication for early intervention. What about band? This is maybe congenital or acquired. Congenital, the classical example is obliterated vitilo-intestinal duct واللي هي ممكن نسوي لنا mical diverticulum or may causing band, just band between the umbilicus and bowel. Okay, a string band following previous bacterial peritonitis. A portion of greater omentum usually adherent to the barytes, especially when there is site of surgery. Acute intussusception. This occurs when one portion of the gut become invaginated within an immediately adjacent segment of the bowel. Almost invariably the proximal to the distal. عادة مو من الدستل للبروكسيمال وإنما من البروكسيمال للدستل. يعني التيرمينال اليوم يطب بالسيكم. أوكي. كولون بكولون لكن البروكسيمال كولون يطب بالدستل كولون. The condition is encountered mostly commonly in children, with peak incidence between 5 to 10 months of age. About 90% of cases are idiopathic. طفل كل شيء ما بيه يلعب فجأة يصير interception ما عنده أي predisposing factor but may associated with the upper respiratory tract infection or gastroenteritis prior to onset of interception may precede the condition. It is believed that hyperplasia of Byers patch of the terminal ileum may be the initiating event. Weaning is associated with the interception because loss of passive acquired maternal immunity and common viral pathogen have all been implicated in pathogenesis in the interception of the infancy. Children with the interception associated the pathological lead point such as Meckel diverticulum, polyp, duplication, Henoch-Schönlein barbara that associated the lymphadenopathy or appendix when it has become inflamed, usually older than those with the idiopathic disease. After the age of 2 years, a pathological lead point is found in at least 1/3 of the affected children. Adult cases are invariably associated with the lead point. Invariably, the adult with the interception should suspect the leading point. Usually, there is a pathological leading point like polyp and Buertel syndrome or submucosal lipoma or other tumor, even malignancy. When regarding the pathology of the interception, when the interception usually composed of 3 points, the entering or inner tube, returning or middle tube, and the sheath of the outer tube, intercepium. The part that advances is the apex. The mass is the interception, and the neck is junction of entering layer with the mass. The interception is an example of strangulated obstruction. أكيد راح يصير بالinterception interference with the blood supply. Okay, the degree of ischemia is dependent on the tightness of the invagination, which is usually greatest at when it is passed through the ileocecal valve. Interception may be anatomically defined according to the site and extent of the invagination. For example, in most children, the interception مثل ما قلنا ileocolic and colocolic interception is common, especially in adult. واضح شباب؟ Volvulus, the fourth causes of the extramural intestinal obstruction is the volvulus. Is a twisting of the bowel or axial rotation of the portion of the bowel about its mesentery. This is a definition of the volvulus. When the complete it form a closed loop obstruction will be result to the ischemia secondary to the vascular occlusion. Volvuli may be primary or secondary. The primary form occurs secondary to the congenital malrotation of the gut, abnormal mesenteric attachment, or congenital band. Examples include valvuli unatorum and sigmoid volvulus. Most common is sigmoid volvulus. A secondary volvulus is usually more common. A variety is due to a rotation of a piece of the bowel around acquired adhesion or stoma. عادة acquired adhesion due to previous surgery make this adhesion make a nidus for rotation of the bowel on its mesentery causing volvulus. Sigmoid volvulus, this is rare in Europe and USA, but more common in Eastern Europe and Africa. Indeed, it's a most common cause of large bowel obstruction in the indigenous Black African population. Rotation nearly always occur in the anti-clockwise, يعني عكس عقرب الساعة, rotation of the bowel. This is a picture of the causes of the sigmoid volvulus. There is narrow attachment of the mesentery, overloaded pelvic colon, and maybe long pelvic mesocolon with the adhesion at the apex of the loop of the bowel. All these factors causing the bowel to be twisted on its mesentery. Internal hernia is rare, but need high index of suspicion in any acute abdominal condition. Internal hernia occur when the portion of the small intestine become entrapped in one of the retroperitoneal fossa, which is naturally is present in the abdomen, or in the congenital mesenteric defect. Following are potential site for internal hernia, for example foramen of Winslow. كلكم تتذكرون بالاناتومي foramen of Winslow اللي هي foramen of the lesser sac, hole in the mesentery or hole in the transverse colon, defect in the broad ligament of the uterus, congenital or acquired diaphragmatic hernia, duodenal retroperitoneal fossa, cecal or appendiceal retroperitoneal fossa, intersigmoid fossa. Internal hernia in absence of the adhesion is uncommon, and pre-operative diagnosis is very rare. Usually diagnosed when the explorative laparotomy done for patient with acute abdomen, and the surgeon will be discovered the cause of this acute abdominal condition is internal herniation. What about the obstruction from the enteric stricture? When there is stricture, small bowel stricture usually occurs secondary to TB, عادة fibrosing type of the TB تذكروها, or due to Crohn's disease. Crohn's disease usually it is chronic Crohn's disease lead to the chronic inflammatory scarring that lead to the obstruction. Malignant stricture is associated with the lymphoma are common, whereas carcinoma or sarcoma is rare in small bowel. Bullous obstruction, the bullous obstruction in the small bowel may be caused by food, gallstone or trichobezoar, phytobezoar or stercolith or worms. Gallstone as a cause of intestinal obstruction is very rare, occur in elderly, secondary to the erosion of the large gallstone through the gallbladder wall ومن ثم to the duodenum, leading to the impaction usually at the narrowest part of the bowel اللي هو about 60 cm proximal to the ileocecal valve. The patient have recurrent attack of obstruction, and usually the obstruction is incomplete. There is partial intestinal obstruction. Other laparotomy, it may be possible to crush the stone within the bowel wall. Need no opening of the bowel to extract the stone. Just crush the stone within the bowel, and the leaf intestine will be open, and gallstone will be passed through the fecal material. Food bullous obstruction may occur after partial or total gastrectomy, when the unchewed article of the food can pass directly to the small bowel. Fruit and vegetable are particularly liable to cause obstruction. Trichobezoar and phytobezoar, these are firm masses of indigested hair, ball, and fruit vegetable fiber. The former is usually is due to persistent hair chewing or sucking, عادة associated with the underlying psychiatric abnormalities, especially in young female. Predisposing position to the phytobezoar result from the high fiber intake, inadequate chewing, previous gastric surgery, or hypochlorhydria, and loss of gastric empty pump mechanism. What about worm? It is very rare in African or in tropical countries. Ascaric lumbricoid may cause low small bowel obstruction, particularly in children, usually in institutionalized child and those near the tropics. What about the clinical picture of mechanical intestinal obstruction? The diagnosis of dynamic intestinal obstruction is based on the clinical background of the pain, distension, vomiting, and constipation. These four cardinal symptoms of intestinal obstruction is present in any type of intestinal obstruction, but with change in the consequences of this feature. Obstruction may be classified into two types, either small bowel obstruction, whether high or low small bowel obstruction, or large intestinal bowel obstruction. High cardinal feature. The nature of the presentation also may be influenced by the whether the obstruction is acute or chronic, or acute or chronic, or subacute. Acute obstruction usually occur in small bowel obstruction, while when sudden onset of severe colicky central abdominal pain, distension, and early vomiting with and the last of story, the constipation. واضح شباب؟ While the chronic obstruction is usually occur in the large bowel with lower abdominal pain, usually colicky, and absolute constipation, which is followed by distension, then vomiting. So sequences of the feature is differ between the small bowel obstruction and large bowel obstruction. Presentation of the large obstruction may be influenced by obstruction is simple or strangulated. When there is simple intestinal obstruction, when the blood supply is intact, and when the interference to the blood flow called strangulated intestinal obstruction usually occur in the hernia ring or intraperitoneal adhesion or band. The clinical feature vary according to the location of the obstruction and the age of obstruction and the underlying, not age of the patient, the period of the obstruction. I mean by age of the obstruction, the period of obstruction, underlying pathology, and the presence of the or absence of the intestinal ischemia or interference with the blood supply. Pain is the first symptom encountered. It occurs suddenly and usually severe, colicky in nature, and usually central or umbilical area in the small bowel and lower abdomen in the large bowel. Development of severe pain is indicative of presence of the strangulation. When the pain is become continuous and severe, the onset of strangulation should be suspected. Pain may not be significant feature in post-operative simple mechanical obstruction and does not usually occur in paralytic ileus. Pain, it is absent in a dynamic intestinal obstruction. Vomiting, more distal the obstruction, the longer interval between the onset of the symptom and the appearance of the nausea and vomiting. كل ما يكون الobstruction بعيد كل ما onset of the intestinal vomiting is less. The obstruction progress character of the vomit is altered from the digested food to the fecal material as a result of the presence of the enteric bacterial overgrowth and the presence of the fecal material in the vomiting or in the NG tube is considered by some as indication of surgery. Distension and small bowel, the degree of distension is dependent on the site of the obstruction. Greater distension when the more distal lesion. Visible peristalsis may be absent, may be present. Distension is delayed in chronic obstruction and may be minimal or absent in the presence of the mesenteric vascular occlusion. Constipation, this may be classified as absolute constipation, which is neither fecal material or flatus is passed, or relative constipation when the flatus is passed. Absolute constipation is a cardinal feature of complete intestinal obstruction, but it is not present in the following, which is not present the constipation. Rachter hernia mean part of the bowel is inside the sac of the hernia, but the continuity of the bowel is okay. So there is no constipation or obstruction. Gallstone ileus, مثل ما قلنا, there is partial intestinal obstruction. Mesenteric vascular occlusion, there is no absolute constipation. Obstruction associated with the pelvic disease and partial intestinal obstruction is the cause of, there is no constipation in the presence of the intestinal obstruction. Other manifestation of the intestinal obstruction is dehydration. It's seen most commonly when there is proximal intestinal obstruction, like in small bowel obstruction, because of repeated vomiting and the fluid sequestration. And it results in dry skin, tongue, or poor venous filling, sunken eye, oliguria, and the blood urea will be increased, and hematocrit will be raised, giving rise to secondary polycythemia. Hypokalemia is not a common feature in simple mechanical intestinal obstruction, and increase in the serum potassium, amylase, lactate, dehydrogenase may be associated with the presence of strangulation and perforation as a result of leukocytosis or leukopenia. Pyrexia in the intestinal obstruction may indicate onset of ischemia or intestinal perforation and inflammation that associated with the obstructive disease. Hypothermia may indicate septic shock. Abdominal tenderness, local tenderness indicate bending or established intestinal ischemia. The development of the peritonism or peritonitis indicate overt infarction and or perforation. Okay, Shabab. What are the clinical features of strangulation? When the abdominal pain becomes constant, not colicky, the feature of strangulation should be suspected. When there is tenderness with the rigidity and when the patient have shock state. In addition to the feature above, it may be noted that the presence of shock indicate underlying ischemia. And bending strangulation, pain is never completely absent. Symptoms usually commence suddenly and recur regularly. The presence of and character of any local tenderness are of great significance, especially as indication of surgery. What about the clinical picture of any individualized cause of the intestinal obstruction? What about the clinical feature of the interception? مثل ما قلنا the classical presentation of the interception when the child have episode of screaming and drawing up of the leg in a previously well male infant, عادة occur in male infant. And vomiting may or may not occur. Initially, the patient will be pass stool, may be normal, whereas later the stool will become blood-stained and with mucus give a characteristic appearance of red currant jelly stool. The abdomen is not initially distended. Lump that harden on the palpation may be discerned or may be present in only 60% of cases. Feeling a mass in the, especially in the right side of the abdomen. And 60% of cases will be felt. There are maybe associated feeling of emptiness in the right iliac fossa, called sign of dance. On the rectal examination, a blood-stained mucus may be found on the finger. Occasionally, an extensive form of the interception, ileocolic or colocolic interception, the apex may be palpable during the BR examination and should be differentiate it from the prolapse, rectal prolapse. Unrelieved progressive dehydration and abdominal distension from the small bowel obstruction may occur, followed by peritonitis secondary to gangrene. When delayed cases of interception, gangrene to the small bowel unfortunately will be occur and the patient presented with acute abdomen. Rarely the natural cure may occur. الشيء الزين بالموضوع انه ممكن انه naturally relief of interception without any intervention and release of the interception is naturally occur. Differential diagnosis of interception, acute gastroenteritis, Henoch-Schönlein-Barbara, and rectal prolapse is very important to differentiate because the management is so different. Clinical feature of the volvulus, sigmoid volvulus, the symptoms are of large bowel obstruction, which may be initially be intermittent, followed by passage of the large quantity of the flatus and feces. Abdominal distension is an early and progressive sign. عادة الشيء المميز بالvolvulus there is abdominal distension. It's very progressive, which may be associated with the hiccup and reaching due to irritation to the diaphragm from the distended bowel. Vomiting occurs late and constipation is absolute in volvulus. What about imaging of the intestinal obstruction? Erect abdominal film are no longer routinely obtained and radiological diagnosis based on supine abdominal film. An erect film may be subsequently be requested when further doubt is exist when you take a supine abdominal X-ray. When the distended with gas the jejunum, ileum, cecum, and remaining colon have characteristic appearance in the adult and the older children that allow them to distinguish radiologically. In the intestinal obstruction, a fluid level, air fluid level appear later and then than the gas shadow, as it takes time for gas and fluid to separate. These are more prominent on the rectal or erectile film. In adult, too inconstant fluid level is considered to be normal when in the duodenal cup and other in the terminal ileum. In the infant, less than 1 year old, a few fluid level may be physiological. So in infant and 1 to 2 air fluid level may be normal and insignificant. A barium follow-through is contraindicated in the presence of acute intestinal obstruction. I may be life-threatening due to my causing perforation and causing barium peritonitis. Impacted foreign body may be seen in the abdominal radiograph. In gallstone ileus, gas may be seen in the biliary tree with the stone visible in the small bowel. This is a characteristic appearance or finding, radiological finding of intestinal obstruction that show air fluid levels centered in the abdomen with the presence of the convenientis, which is a feature of a small bowel obstruction, while the large bowel obstruction is usually occur in the periphery of the abdomen and the presence of the hustera. Okay. Imaging of the interception, إلها خصوصية الانتسبشن. A soft tissue opacity is often visible in children. A barium minimum may show a characteristic sign called glow sign. glow sign عفوا اللي هي إذا تشوفوني الصورة لا ما تشوفون.
نعم دكتور.
بالضبط glow sign. هاي الساين glow sign أعتقد موجودة بواحدة من الصور. Okay, this is called glow sign لأن هذا باريوم وهنا الانترسبشن راح يجي فالباريوم راح يصبغ بس هاي الاريا وهاي بول هنا فيصير glow sign. Abdominal ultrasound can show high diagnostic sensitivity, especially in children, demonstrate a typical definite appearance of concentric ring and transverse section. It is very clear by ultrasound the interception. A computerized tomography CT scan will be helpful in equivocal cases. So the investigation of the interception is X-ray وباريوم انيما باريوم ميل عفوا باريوم انيما و that show glow sign ultrasound which is show definite appearance of concentric ring especially in the transverse section, and CT scan is diagnostic in equivocal cases of interception. This is a glow sign. هاي الجلو ساين اللي هي موجودة. باريوم انيما يدفعون انيما باريناس يلون المكان كله لحد وصل للهيباتيك فلكشر اوف ذا باول اللي هي هنا area of interception. Radiological imaging of the volvulus and cecal volvulus radiograph may reveal a gas-filled ileum and occasionally distended cecum. Barium enema may show to confirm the diagnosis with the absence of the barium in the cecum and bird beak deformity. A bird beak deformity هاي موجودة الساين هواية موجودة حتى لا تذكرونها بعدكم ما أخذتوا الأوزيفيغاس بالكليزي كارديا موجودة. In sigmoid volvulus, a plain radiograph show a massive colonic distension. The classical appearance is a dilated loop of the bowel. Okay, اللي هو half bean sign يسمونها half bean sign. وصلنا للتريتمنت اوف intestinal obstruction. إذا عندكم أي سؤال اسألوا. intestinal obstruction موضوع مهم جدا وخاصة بالإمرجنسي راح تشوفون various type of intestinal obstruction especially in emergency or casualty. بالإكزام بالكلينيكال examination of the abdomen قصدك يعني when we found the previous scar, for example, we should suspect when there is could be the cause is adhesion, when the patient have a previous surgery, okay, and when there is visible peristalsis, especially that evident in the thin and young patient. It is mean that the cause of obstruction is mechanical intestinal obstruction, and when there is no the clinical examination, the abdomen is rigid. Sometimes we suspect we have perforation or ischemic bowel. Okay, during the abdominal examination, مثل ما قلنا بالinspection when we found there is progressive distension of the bowel. Okay, goes with the volvulus of the sigmoid volvulus. واضح؟ when the scar ممكن adhesion. مثل ما قلت لك يجوز ممكن المريض is suspected to have malignancy, يعني jaundice, emaciated, weight loss during general examination. Could be the cause is tumor مثل ما قلنا mass or malignancy. واضح شباب؟ children عنده lymphadenopathy مثلا cervical lymphadenopathy and ممكن نشوف ممكن interception، ممكن هينوكشولين بربرة إذا عنده rash, especially in the rash of the extensor surface or butic اللي هو characteristic rash of the هينوكشولين بربرة. Okay, which is one causes of the interception. So the clinical examination may give a clue about the cause of intestinal obstruction. early surgery والمريض مضمد بعد بضماده وعنده abdominal distension, you should suspect there is a dynamic intestinal obstruction like paralytic ileus. ما تروح تفكر بالفالفولاس وتفكر بالتيومر إذا هو المريض early surgery، تفكر بالباراليتيك ileus أكيد يعني. أوكي شباب؟ أعتقد بعد